This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I'm Mirana Parks, physical therapist and your host, and today I interview Annie O'Connor about subgrouping chronic pain. We will discuss how subgrouping the central nervous system is key to personalized pain science education and cognitive behavioral therapy, the factors that lead to persistent pain, the appropriate use of acceptance commitment therapy and motivational interviewing, when it's necessary to use graded motor imagery and when it should be avoided, and much more. Annie is a physical therapist with over 30 years of experience, OCS and MDT certified, and she is the founder and CEO of World of Hurt, a company dedicated to teaching, consulting, research, and clinical practice of the pain mechanism classification system. She also co-authored the 2015 book, World of Hurt, A Guide to Classifying Pain. If you feel this information is valuable, I encourage you to subscribe to our channel, hit the notification bell for updates, give us a thumbs up, and share with other clinicians who could benefit from this information. Thank you for tuning in, and we hope you enjoy the show. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like Systems for PT, the Do Anything Anytime EMR. Systems for PT develops systems for clinicians so you can focus on your patients. Go to systemsforpt.com to schedule a demo today. Sarah Health. Remote therapeutic monitoring sounds great, but also difficult. Sarah Health makes RTM simple and easy for your patients and providers. Check out sarahealth.com/PTProTalk for a special offer. Hi Annie, welcome back to PT Pro Talk. How are you today?
I'm good, Marina. Thank you for having me back.
Yes, I'm glad to have you back, and we've been talking about this episode for a while. So I'm happy to bring you here so we can talk about the subgrouping of the central nervous system. So before that, let's just talk a little bit about yourself and your background for the ones that don't know you. And just mentioning, Annie was here before on the episode 84, sorry. So go back and listen to that if you haven't, because it was a great episode.
Well, thank you for having me back. And I agree, that was a great episode. We really got innovative with the use of, mechanical testing in the neurological population as it, pertains to spasticity and hypertonia and the mindset that, geez, these symptoms could be coming from the peripheral nervous system, right? So yeah. I really enjoyed it myself. And I love what we're talking about today, where we're trying to take, something that we value very much in classification or subgrouping and, really go, can we apply this same methodology to the central nervous system? So our first episode, we took peripheral nervous system subgrouping into a centrally dominated neurological population. And now we're coming at it with the musculoskeletal system, which, by all intents and purposes, everyone wants to believe it's nociception, and saying, can we subgroup the central nervous system on the peripheral side of musculoskeletal pain? So I just feel like, wow, what a dichotomy that you and I are going to do in these two episodes. And hopefully listeners, if they enjoy what they're hearing, they hear that, because that's really what's happening. Yes, I'm Annie O'Connor, and I am the physical therapist by trade. I am the founder and CEO of a World of Hurt LLC. And I also am the clinical account director for Elevance Health Back and Joint Guide Program. And so I got a lot of different little hats I get to wear. And my most important hat is the hat I want to talk about today, is I'm a clinician and I'm in the trenches, and persistent pain seems to follow me everywhere.
How many years that we were talking about that you mentioned that you were,
I did. I graduated PT school in 1986. And boy, did I come out thinking, look out, they haven't seen anything yet, right? Only to really, get in the clinic and, thinking I knew everything, and nothing's working. And, the foundation of which, my education and pathology and anatomy wasn't cutting it. And the frustration I had gone through, as I was sharing with you from 1985 until this information that I want to talk to you about in 1995. So 10 years later, after seeking about every level of continuing ed course you can, to how do we do this? How do we help people in pain? And, to keep coming up kind of like, well, that didn't work. That doesn't work. That doesn't work, and well, maybe this whole profession of physical therapy is kind of worthless. What's next? Let's do osteopathic school. Let's go chiropractic. Let's do all this. Let's go to management, let's do all these things because we can. Only to see David Butler speak at Combined Sections 1995 on the concept behind subgrouping with pain mechanisms. And he presented the subgrouping of the central nervous system. And light bulbs went off. Oh, that's why that works there and that works there. And I'm not organizing my thought process relative to factors that are driving persistent symptoms. And, and I think other great classification systems pick that up. You and I were sharing. I think Robin's whole intent with the other was to really, especially the other chronic pain, was to really identify that, hey, at some point, even James Syriac's in an earlier quote, look, if these persist, the psychosocial issues may start dominating. And so when they are, how are you, clinician, organizing yourself to pick that up, screen that, and realize the predictability of people screening with these different mechanisms, factors, however you want to reference it, I really don't care. How well are you picking them up? Because they need to be dealt with if you think that your mechanical approach is going to have a response. And so that's where I felt like we were going to be today, was talking about a passionate topic that I have since 1995 and what inspired writing a book relative to the classification of pain mechanisms. And, so I don't know where to go from here, but I appreciate the intro and just, I wish we had people out there telling us all the stuff they want to hear, right? But we're gonna hope that, between you and I and the struggles we all have in the clinic, we'll probably make it happen for them. Yeah.
Hopefully so. So we were talking about to be able to treat effectively, right? We have to be able to know how to direct these patients to the appropriate approach. So let's just briefly start talking about the subgrouping, just for the ones that are not familiar with. So how do you subgroup them? And then after that, I guess we can start matching them with the right approaches.
Yeah, that makes a lot of sense. Well, if we're talking about the central nervous system, we're talking about the brain. We're talking about the DRG. That's technically, if we're in dissection class, where the central nervous system begins. Because proximal to the DRG, we're at the nerve root. So that's very susceptible to, as we all know, common things going on within the motion segment. But once we go proximal to the DRG, we're in the central nervous system. If I continue the nomenclature within the pain mechanism classification system that Louis Gifford and David Butler brought to the world in 1995, one of the groups they reference is called central sensitivity. And this is a group out there that people are more and more recognizing, and more approaches are designed for the cognitive functional therapeutic approach with Peter O'Sullivan, beautifully designed to manage people that are dominated by that subgroup. The DIMS and SIMS of the NOI group, another very effective approach for people dominated by central sensitivity. And what does it really mean? Like when we kind of think about that, it's really, misinterpretation or overinterpretation of nociception. It's an input to output mechanism. It needs nociception. And relative to the perceived thinking and believing of what that nociceptive signal really means as it enters into the thalamus, right, who decides whether I should protect or not protect, and consults with the amygdala and all the stuff that's been going on in my life, they come to a conclusion. This is dangerous. This is not good. This is not safe. And if I continue to do that, I could do more harm. And that is, facilitation of the nervous system in protection. And so it's a mechanism factor that's built off of the thinking and believing relative to the person that is going through. It's also been referenced as the fear avoidance pain mechanism. These people who are catastrophizing or medicalizing or, who, just really don't appreciate sometimes what movement safe pain really is, right? And haven't been given the secret sauce of check your range of motion. It's unchanged. So we know it's safe. And, and we just haven't really screened for that and help them understand. So it's a widely known group. Has comes in a lot of different names, right? But the root to that is, I believe I'm doing harm, and I don't know that pain is safe. And one thing I like to say about as we're discussing these groups is, don't do that to yourself if you're a clinician. Believe that all people who don't understand movement safe pain are catastrophizers, because they're not. Many people on simple screens are unsure. And as soon as they're unsure, you can bet your paycheck that thalamus went to protect, not no protect. Mm-hmm. Because the brain will default to protection. I mean, it was an organ built to protect. So, and that's in normals, you and me. So that means probably the people we serve too. Now, that's an input to output mechanism. David and Louis also addressed a mechanism they called the effective pain mechanism, which is an output mechanism. It doesn't require nociception. And I love Dana Green when he teaches about this at the McKenzie Institute, because he talks about, they just need to remodel their coping. I kind of agree with him. I don't know if I could simplify it in that way, but it's a good way to think about it. It's really a factor that's dominating where people are not coping, and they're not coping emotionally and socially. And very few are psychological. And most of them are driven off of the persistent loss of confidence in the condition management, confidence in their health, confidence in, God, how do I control this pain without taking drugs? They've lost hope. They've lost hope that they're going to get back to their normal self. And so, how do you screen someone who's, more dominated by these affective factors that are more emotional and social? Because they're not the same as the ones that got stinking thinking relative to fear of movement, right? They're different. And I feel like this is where you may have scratched your head in the clinic, because many of us, go back and forth between these two factors. And, whether we missed one dominating or the other, we didn't know how to tweak the program a little bit to get that right response. And, So that's like that second central nervous system group is relative to those affective factors that are wrapped around emotional social coping. And then that third group that Louis and David brought forth, again, another output mechanism, not requiring in nociception, is, what they termed the motor autonomic, which really, if you had another way of thinking about it, because we know the great work of Ramachandran brought forth when he realized phantom pain. How the heck can someone hurt in a limb that's not there? Well, damn, we got a small little limb within our motor and sensory cortex that has representation. Well, that's easy to pick up when they don't have limbs. But what about when they have limbs? And that was really some of the great work that Lorimer and all of them did early on when they started to realize that people could really lose representation of certain body parts relevant to persistent symptoms. And even some of the early studies in 1995 showed that could happen in axial low back pain, in persistent pain. And so how do you know that I'm actually dealing with an output mechanism that's not really yellow flag related, like stinking thinking and believing or emotional social coping, but it's really related to the fact that I have just decided in my brain to re-represent that body part as a protective mechanism and smudge it?
That's a great question.
It is a great question. It is. And, we don't, at this day and age of research, we don't have research that has gone into this level of, methodology. We have a ton of research supporting every one of those mechanisms. We have great practical work that's been done by a lot of clinicians in this area on how do you differentiate one versus the other. And then what does that mean for treatment? Because it's not about giving them all the same thing or the same education. In fact, we already see this not working in pain science, right? I mean, you can't, each one of them deserve to have a different explanation to why they hurt. And, it's not about just giving them the big umbrella, the brain, and sometimes you don't even have to explain it relative to the brain, but a clinician needs to understand it relative to the brain. And a patient may not need to understand it relative to the brain. They need to understand it relative to the factors that are driving the persistence. So I hope that kind of wets the whistle a little bit, or, gives you an idea of these kind of three known subgroups within persistent pain.
And now the question to how to identify them, like what are the main things that tell you which one is each group? Isn't like something that they say, how they behave. So how do you identify it?
I would say characteristically, as we've outlined in the book and the courses, is it's no different than what we normally do. Think location of symptoms. Central sensitivity is going to have the presence of widespread symptoms, non-dermatomal. Where somebody really dominated more by the affective mechanism could look very much like a dysfunction, where it's very localized. And they could actually have multiple isolated symptoms that seem to rotate. I know clinicians have had these in the clinic, have these patients in the clinic. You're working on their hip, everything's going great. You're getting ready for the discharge. And they come in that day and they said, I don't know what happened to my shoulder. Your shoulder? Geez, you never even say anything about your shoulder, and you're like, yeah, well, how about the hip? The hip's not a problem. It's my shoulder. And, they're realizing that they've got this therapeutic alliance with you, and those sessions with you have been geared toward some active coping And their brain's intuitive enough to know that, hey, shoot, man, they're getting ready for the discharge here on the hip. If you don't get another problem, babe, you're not going to get another visit, right? So let's wake up the old shoulder problem. And that'll get you a couple more visits with this wonderful person who's helping you cope. And so the effective mechanism alone isn't a widespread pain mechanism. But you often hear people have multiple rotating symptoms. They have very stressful lives. They may have a bit of a negative outlook. And if you're doing good, yellow screening, you're seeing self-efficacy and confidence, and depression and anxiety and sleep are very much impacted, but, versus the widespread pain mechanism of motor autonomic, you got to be really kind of careful because they can come with what appears to be a complex regional pain. So CRPS 1 or 2, or the RSD of old, where they really literally have objective skin findings, because think about it, the brain's losing representation of that body part. And the skin is the largest organ in the sensory cortex. So it could really actually change the representation of it. So you've got a disinhibited mechanism over here that you may pick up in location of symptoms. You've got a widespread facilitation mechanism. They got pain spreading to effect. You've got maybe multiple sites that don't seem to be apparently connected. So location of symptoms can help you. Frequency of symptoms can help you. Your central sensitivity and motor autonomics usually admit to constant-based symptoms. Motor autonomics are constantly the same. Central sensitivity will change intensities relative to the context. So if I'm in a bad place where I don't feel safe, my pain's going to be high. If I'm in a good place where I feel safe, my pain will be low. Because the threat is different relative to the context, because the context drives sensitivity, interpretation, where the effective mechanism is really a low-grade mechanism to begin with. You don't see a lot of severe symptoms. It's just low-grade, moderate pain. And it doesn't seem to be impacted by a lot of things they do. They love touch care. They love palliative care because it makes them feel positive about themselves. And so you may hear a lot of things, I've tried that, it's not working. I've gone through therapy. I've gone through chiropractic care. They love manual therapy, so they like relationships, especially relationships that make them feel positive. And so you can hear all this within the location and frequency, bettering and worsening, no different than what you would do mechanically. But they may give you a little bit different tangible answer that doesn't fit your derangement, dysfunction, posture.
And how about the fear avoidance?
How do you screen it? Let's say we don't do a psychosocial screen.
When you start moving them.
What do you see? Yeah. You see apprehension.
Yes.
You see apprehension more than obstruction. And if you're kind of gifted at seeing that, and then you figure out a different way to make them do a movement that's in a different orientation or context, all of a sudden they move differently. You're starting to confirm that, not that they're faking it or something like that. You just basically are seeing one context be threatening and one not. But yeah, you'll see apprehension versus obstruction all the time. And your ability to differentiate that rapidly in order to make those diagnoses between a derangement versus a central sensitivity mechanism, be it that they're only 1 millimeter apart, the DRG from the nerve root, seems to be important.
Yes, absolutely. Very important.
Yeah, I feel like it's a great topic to talk about because often people have the perception that centralization is occurring when what might be really occurring is I feel safe with you. So when I'm doing these movements, I'm having less pain.
But they don't stay better when they leave.
See, you already know them. Or they cannot replicate what you do in the clinic.
Mm-hmm.
See, it's just the way you put your hands. See, I can't get my hands in the right place of your hands. And these are really, things that we have to pick up, because we all agree on this. We're going to do extension and standing, extension and lying. And this person's calling me up the next day with pain that's worst ever in their leg. Right away, oh gosh, this is, peripheralization. They got to be a lateral. Now we're shifting their hips off center. We're at the wall, jamming it up. And, but really what we may be getting is, I don't feel safe doing what you're giving me on my own. Or I don't understand that spine pain is good. So these are really important clinical, tangible, practical things, because that first big subgroup of the central nervous system, central sensitivity, is so closely aligned with what we see at the motion segment just by the proximity of the DRG anatomically alone, and that it has its own gray matter and can actually influence nociception relative to the context environment that I'm in. Boy, we better be on, because we're making a 1 millimeter call relative to a repeated movement assessment. And this is why I'll always say to a clinician, man, use a screen. Because when you want to know before you're walking down the hallway with somebody, if they're kind of testing high in a fear avoidance domain, it may be worth your time and effort to kind of have rules of what movement safe pain is before I go enter into a repeated movement exam. Because the information I may not get credible information. Or worse, this is what happens all the time, right? You see major baseline movement changes, but they don't see it.
Mm-hmm.
That's another factor I bring to the awareness of the clinician. If you ask them, hey, what influence did that have on your movement? None. I still feel the pain. And you see a 50% gain in mobility and side glide or, shoulder range of motion or whatever you're using as a baseline. And that person didn't pick it up. And you almost felt inclined to tell them, well, look at how much your movement changed. Buyer beware. That person just coughed up to you that they're more than likely centrally dominated. And, unless they view this as a safe exercise, you could get a big email, big voicemail. Because the one thing about the central nervous system is it has no timeline. So it can have a latency response that could be minutes later, hours later, weeks later, when they start processing what was done in your session with them. Because the central nervous system has no timeline, like the peripheral nervous system. Yeah. And the central sensitivity group is the largest subgroup. Do you know it's also the group that can have a rapid response? Not if you get your moves right, but if you get your words right, it could.
And that's what, as you were speaking, I was just thinking about it. I feel now very, I don't know, they're purely mechanically, it's less and less because they have so many factors in chronic pain and so many months feeling that it's almost like you have to clear all that up before you can do a good mechanical assessment in many patients.
And why the intervention for somebody who you believe is more dominated by those factors would be to initiate right away the concept behind movement safe pain, right? And really giving them a trustworthy baseline outside of their pain. Pain lies, motion doesn't. And so it may behoove you more in that first session to really help them appreciate that by doing this activity that you're concerned about doesn't change the motion. So we know the pain you're feeling is safe and the condition is stable, and you'd be better off doing it than not doing it. And returning that analytical skill to them. And so the must-haves in central sensitivity is they must have the ability to discern this is safe. Mm-hmm. They must be able to have a trustworthy baseline that they can trust, whether it's a function or emotion, they can trust, not the therapist can trust, they can trust, that gets them to analyze this differently. And they must have begun gradually exposing themselves to things they're avoiding. And so if we would take that first session, lay that foundation and get them gradually exposing and using that traffic light mindset and practically using that skill, we may get to the second session where we can actually do something more credibly mechanically to really see if they have an underlying mechanical syndrome that should be formally treated. And not wait till session number 6, where we've dragged them through all kinds of stuff that hasn't made sense. And depending on how we're educating relative to that session, we may be having nocebo, responses because we're losing our own confidence. We're changing our verbiage. Mm-hmm. We're coming in with different tones. And these people are very perceptual of their environments around them,
Mm-hmm. Yes.
So I always say, they know where every one of your nociceptors are too.
Yes, it would be great if everybody had that view. So I think this conversation is just awesome because it helps us see, and not just see, but then know what to do next.
Yeah, just take a step back and, be a true partner in the assessment of safety. Share the secret sauce, how we know. Because I feel like when you take an intelligent, analytical person and you give them a different way of analyzing, they literally can turn their entire central nervous system from chaos to calm. Now, those are the ones that are ready to receive. You've got people that have strong beliefs, right? And they may, you might have to do several sessions of watering before you get that one to blossom. Because the beliefs they have are so strong relative to what they've read, what they've been told, and how many clinicians they've heard, and, a lot of kind of, so there's other things there that, they may be putting up a lot of resistance,
And what do you use with those patients that have strong beliefs?
Well, let's agree that when we have people that are kind of, using the words yes, but yes, Marina, I hear you that my pain is safe, but I have the worst disc ever on MRI. Yes, Marina, I hear you that I need to get back to these things and I've been avoiding them for a long time. And you're right, by avoiding them, I haven't gotten better. But my doctor's telling me that I really need the injection before I go forward with your care. So let's agree, when we hear the signs of resistance, which usually come in a yes, but form or a yes, and, you've got somebody who, as much as you want to do a cognitive behavioral technique, like we just talked about, explaining traffic light guides and gradually exposing them, they really are in what we would consider more of an approach like motivational interviewing. They're not, motivational interviewing is how you deal with resistance. You don't do cognitive behavioral therapeutic pain science education to a resistant person. They'll yes but you through the entire session, and they'll dig their heels in deeper, right? So resistance means switch approaches. Same mechanism, different approach. The clinician dealing with resistance has to be able to switch gears. Yeah. Now, what is that, though? What is MI? Can you tell me what motivational interviewing is?
I cannot.
Oh,
I think it's...
I'm going to make it so simple for you. After 9 courses, I finally figured it out. Yeah. You think it's what?
I mean, I would say probably like while you are like talking to the person, I don't know, trying to explain things. I don't know.
I love your honesty. You have the face that can do MI, so I just want to let you know. And you have the smile that can do it because you come very personable. And often you hear this taught in motivational interviewing or reflective listening courses, or however we're selling this, is that you need to be more personable than professional. All right. Now, having a foundation of that, you also have to have an open heart to change a mind. You got to change a heart to change a mind. Okay. And that's where I feel sometimes clinicians have a hard time applying the basic principles of MI, is because this one doesn't want to change. We have our own preconceived cold heart relative to what's happening. All right. So wear the right face, wear the right smile, open your heart. Because if we can't do that, then these principles that I'm going to give you that are like magical aren't going to work. All right. Number 1 principle, the MI that everyone should understand and utilize when they hit resistance, is called validation. Thank you for sharing that with me. I did not realize that you thought the injection needed to happen prior to the therapy. That makes so much sense to me now. I really appreciate you explaining that to me. That's a validation statement. Because once I have a validation statement relative to the context of the resistance, I'm now in the second place, which is a huge place. Validation, step 1. Permission, ask permission, step 2. Can I share with you why the doctor thought and sent you to me prior to you getting the injection? Can I share with you why he thought that may be a good thing? So I validated the concern in the context.
Mm-hmm.
And then I set up to ask permission to why you were sent to me and why the doctor thought that would be good. And now that person's in a choice point 1. They either say, yeah, heart open. No, thank you for telling me that. Is there anything else that I can do for you today? Right? Because the last thing you're doing with resistance is just to keep meeting resistance, right? Conflict never works. It just doesn't work. Yeah. So if that person says yes, then you are now, principle number 3, able to provide information with the consequence, right? So thank you for giving me permission, because I think this is something that's really important, and I've seen this often. That's why your doctor is referring you to me. We see that the injection may not work, and we see sometimes that the movement therapy may help the injection to work. So they often will have us do the movement screen prior to the injection. Because the movement screen actually can predict how good the injection is going to work. Now, if we don't do it, right, and we wait, we may not see that the movement screen can actually have that effect. So I provided information relative to the context. I had a soft consequence. And now this person's sitting, ready for me to do principle number 4, put into a choice point. Can we go forward with the movement screen that you were referred here for? Yes? No. So MI is a really strong approach when you have resistance. And if you cannot organize your conversations around those principles relative to the context by which you're having the resistance, you may not be able to get them, right? A different heart, which gives them a different mind, which gives us a different opportunity, you know?
And it's funny how I feel like when you're talking about it, like we do kind of that like instinctively, like it's natural because you know it's not gonna work if you don't stop and talk to the person and try to, you know, do the steps. I mean, I never heard that organized like you said, but trying to get their consent and explain things, it's not gonna move forward.
Right. But I feel like what step gets missed the most after watching many clinicians do this, and even when I make my own mistakes, is validation. We want to receive consent prior to validating. And receiving consent is different than asking permission. So I do feel like if this is something that's meaningful to your practice and you're meeting a lot of resistance, you probably have already figured out the old information consequence choice point, but you're probably going to have to sharpen your skills in validation and ask permission. And making sure you're wearing the face that comes along with that. After you're doing how many points of care and how many people on your load, and right. And that's an art. There's no science on that, you know.
Just using your soft skills.
Sometimes, I guess, you know. But it's a really good thing to talk about because when we're in the central nervous system, these approaches of cognitive behavioral therapy, motivational interviewing, acceptance commitment therapy are not mechanism based. They're stage of change based. And we have to be extremely dynamic and shifting gears relative to how someone shows up that day. They may show up very pre-contemplated and resistant because somebody said something to them that day, right? Mm-hmm. Or they may come in and be very contemplated where they're telling you, I know I need to do those extension exercises. I know they change my pain, but I can't. My kids, my job, my this, my that, my this. So they're contemplated. They're looking for an accountability partner. They're not looking to be resistance. They're not looking to understand. They're looking for accountability. And, you know, an acceptance commitment therapeutic approach is extremely valuable for someone who's in a contemplated state and needing accountability. And so I feel like as we're subgrouping the central nervous system, we're talking about a parallel importance of what approach for what stage of change.
Mm-hmm. Yes. And then as you were talking about the acceptance commitment therapy.
Yeah.
So how do you define that? Is there like, I know you put like mindfulness approaches. So,
because mindfulness approaches, I feel, are remaining present. We're remaining in the present time. And we're grabbing a control of where we are right here, right now. Okay. And that's really what it, you know, is the essence of mindfulness, is be present. Okay. And when you've got somebody they know everything you're telling them. They just can't do. They got stuck in the Americans, not the American, right? Like, so we need to help them be a little bit more present. So what does that look like? Because acceptance commitment therapy has really good principles, just like MI does. And it's kind of like what it sounds like. It's really it's acknowledge how far you've come and accept what you have to do. Okay. So if you can get people to understand, like, hey, I know you're not doing it exactly, but you're doing it and you've seen connections. Let's acknowledge how important this is.
Mm-hmm.
Okay. It's a different form of validation, but it's an important first step as you're dealing with somebody in this place. But then let's accept that we may not be getting the most done that gives you the most relief. Right. And so once you can get into the A's, then you can get into the C's. Commit. Let's not commit to the long-term goal. It's too threatening and frightening for anybody stuck in contemplation to think long-term. But let's commit to the next visit, what you're willing to do in accountability, because that's what they need. Remain present, commit to the next visit, the short-term goal. Let's be mindful of how far we've come. Let's be mindful of what we still have to do. Let's commit to the next thing for the next session. And then let's follow up. Because if you can operate within those basic principles of ACT, with somebody who's giving you the, I know, it doesn't mean I won't, but I can't. They're different than the yes butters.
Mm-hmm.
If you can be able to shift those gears between MI and ACT and use those basic principles, you'll be really amazed at how you're moving people into prep and action phases, which now they're more likely to have a cognitive behavioral session with you. So these approaches were always geared toward readiness, not toward mechanism.
Mm-hmm. So like, let's see if I got it right. So the motivational interviewing, summarizing, it's more for those that have that strong beliefs, that have a lot of resistance, right? And then the ACT more for the ones that they need more accountability. So they need to, that like you just mentioned that like I know I have to do, but I can't because I have this, and that. So they are different. It's a different resistance. It's not like based on like strong beliefs, are just more the circumstances that you have in your life. You're not able to do it. You're just having a hard time following through.
Yeah. I mean, well, Prochaska's work in stages of readiness, which was all kind of coming out of, the addiction fields, because we were realizing, you can't get people better by telling them, your life sucks because you drink too much. It's just like, that isn't working, right? It's not working in a lot of our habits that lead to chronic illness. Look at the smokers and stuff. So how do you embody change is you solicit them as their experts. And how do you, as somebody who's partnering, because they're being referred to you for that, well, you've got to be able to, use an approach that puts them into the expert seat.
Mm-hmm.
Okay. Now, people who are resistant, I'll tell you, they use the words yes, but, yes, and they have an excuse and they're cure seeking. Okay. People who are contemplated typically tell you they know. And it doesn't mean that they won't, but they can't.
Mm-hmm.
And we can remain contemplated for decades. I mean, look at weight loss, for crying out loud, so look at exercise. I mean, so contemplation isn't something that, we can remain and stay, preparatory steps. People are taking action steps. And if they're taking action steps, then you aren't dealing with these forms of resistance. And you should be gearing yourself toward, CBT as a general overshadowing, why people hurt, what can they do about it, what are you going to do about it, and how long this takes. I mean, that's CBT. You got to be equipped to be able to do that, But you can't get to those questions to answer if someone's yes budding you.
Mm-hmm. Yes.
Yeah. So, good reflective review.
Okay. And
I know you're really feeling positive right now about this.
I'm just curious to ask a lot more questions. So I know that you're mentioned about the, predicting positive outcomes to manual therapy and exercises. So, what are those factors that you think that predict positive outcomes? And I know you mentioned some fear avoidance, confidence, persistent pain, sleep.
Yeah, I feel like those, right now are the top three the evidence probably brings forth. When you think about confidence, I mean, fear avoidance, whether you're using an FABQ, a Tampa 4, a yellow flag risk form, all of these have strong fear avoidant domains within the questionnaires to allow you to know that if they're screening high, they don't understand it's safe to move.
And that's our starting point.
And it should be your starting point, because if they don't understand that, they've already lost confidence in that. They don't have confidence in the condition, and they don't have confidence in their health, and they don't have confidence in their pain control, and they're losing hope.
Mm-hmm.
So it is wise, if you're starting anywhere, screen that. I mean, that's probably even, with recent evidence has been correlated to predict whether a peripheral based intervention is even going to work, your exercise, an injection, a pill. So, that I think comes pretty strong. Sleep is another factor. When people aren't sleeping, they aren't healing. So, whether you need a full-blown sleep questionnaire or you just need a question relative to an NRS scale on how difficult sleep is for you, realizing the more disrupted the sleep cycle, the less likely what you're going to do works.
Mm-hmm.
And confidence is an area, self-efficacy, it's just really, it's their control over the problem, and people that in persistent symptoms, it seems like predictability, I don't want to use that word, but they lose two things in confidence. They lose confidence in the condition itself, and confidence in how they're managing that condition. Doesn't matter what it is. Diabetes, bone on bone OA, I had a stroke, and they lose confidence in their general health. So when we see those two are plummeting, then the likelihood of my manual therapy or whatever exercise I seem to be in this month is going to work. You may really have the right exercise. You may actually doing really good priming manual therapy with the right exercise, but this person has no confidence.
And then what would be the approach for the confidence? Would be the same as for the fear avoidance?
I think it's relative to what the issue is. If it's general health, it may be more about you working on measures toward what it is about their general health. Okay. It's not uncommon to have cardiac histories with pain. And so people aren't exercising because they're very, concerned about the cardiac condition and their general health. And so how are we frame setting through importance scales, using whether it's an importance scale or a different scale to understand, like, I'm needing you to do the walking, right? Which you feel is raising your blood pressure, which is putting you at risk with your heart, right? I might have to show that walking session's not changing the blood pressure or it helped the blood pressure. And my baselines might not be movement on that one. It may be blood pressure testing.
So address whatever their confidence issue is.
Well, know that it's going to be in one or two places for persistent pain: condition management and general health.
Mm-hmm.
And so again, the art, right, of personalized patient-centric care. Yeah. And SF12, love it, but it doesn't give me enough information relative to those areas that I need to get personalized about. I think, so we have to, I feel like we have some growing pains that are going to occur if we're really going to get good at customizing these factors to get the best outcomes. Yeah. I don't want to segue, but I do want to talk about, the whole concept behind the motor autonomic mechanism and when do we really do graded motor imagery?
That was going to be my next question. So go ahead.
I knew we were tracking. Because, look, when we were heavily studying this at the Rehab Institute of Chicago, I mean, that book was written on 25 years of practical application of this methodology in a large urban rehabilitation hospital. Okay. And I bring this up not because this is the prevalence you're going to see in your practice. Everybody's practice is different relative to how they're serving in their communities. But if the largest rehabilitation hospital is having a low prevalence of motor autonomic, where we have to really get to the nitty-gritty of left-right discrimination, imagery, mirror box therapy, building the representation of the brain to get to the body, then you may never see this in your practice, or you may be working in a highly specialized area relative to CRPS, and you may be seeing it every session of the day, right? So the concept behind it is, though, look, if you have to remodel the brain. It's basically a brain dysfunction. Now, when I say remodel, the word remodel to you, what does that mean to you?
Retrained, maybe?
Means time, doesn't it? Remodeling means it's going to take time.
Yeah.
It means frequency. They've got to do it multiple times a day. It means slow change over time. If I can get that person 2 or 3 times a day to do the work, I can get a statistical change in 4 to 6 weeks. It means progressive. It means I'm going to produce and increase the symptoms. And this is where I wanted to go with this conversation, because there is 2 camps on this theory. The camp that will downgrade the GMI approach, whether it's left-right discrimination or graded motor imagery, because they don't want to produce and increase the symptoms. And then there's the camp that has the realistic thinking of, wow, we're just remodeling a brain, so we are going to produce increase, no worse. And, my 38 years in this space, you're going to produce and increase the symptoms in order for you to remodel a disinhibition that's going on within the sensory or motor cortex. And you are going to be progressive. And you do need to start with left-right discrimination. They have to be able to discriminate left versus right in order for them to form an image, in order for you to think you can use reflective therapy. And we do have to handpick these people. And these are people that will show up with 2-point discrimination tests that don't fall within normative values in their symptom areas. These are people, if you do left-right discrimination screening, They will show less accurate and more time in areas of symptoms. So we do actually practically have physical exam procedures that can help you identify that this would be an approach that needs to be hand chosen for this person. The two other mechanisms, affective and central sensitivity, they don't need a GMI approach. Central sensitivity doesn't need any more awareness to a body part that has more awareness.
Mm-hmm.
And how do you know? Like, I'll tell you, I want all the listeners out there, you're going to email me when you do this for the first time. I just got an email last night from somebody and it just made me smile, where you actually did a left-right discrimination test, establish someone's norm within their own body because we have no normative values. And you saw by doing a good 3 trials that that person tested more accurate and quicker in the area of symptoms. More accurate and quicker in the area of symptoms. That is somebody who does not need a GMI approach. They're basically confirming the over-facilitated nervous system. And it's a waste of time and money, and you risk actually delaying their care because you're making them more alert to an already high alert area. But you won't know unless you test. Because that person needs to understand movement safe pain. They need to have a trusted baseline that they can trust, and they need to start the gradual exposure program back to the things they believe that are causing harm. And you would be better served for their time and money if you would focus that than giving them a left-right discrimination app or getting them to do imagery work or using VR and virtual reality. So right treatment, right patient, right time relies on sometimes willing to do testing and reassessment. But that motor autonomic mechanism, if it's dominating, they will always be less accurate and more time in the area of symptoms. Central sensitivity will always be more accurate and quicker in the area of symptoms. Yeah. And I think it's a huge differentiation as you work with those widespread pain mechanisms. Yeah.
And I was going to ask, on your experience, how often do you see patients that need GMI?
Not often.
Not often.
Yeah. Again, I say that relative to the context that I'm practicing right now. But, you know, this is what I'm known for. So I've got tons of people coming to me, and on first visit, I'm running the left-right discrimination testing, establishing their norm, and going, this one's more central sensitivity than MI or than motor autonomic. And so, they're sent to me for this, and I'm thinking, well, we're not going to do that, so now when I was working for Shirley Ryan Ability Lab and within their pain management program and things, that prevalence was a little higher. But it was based on good testing. It wasn't based on just because you came to a pain management center. And it certainly wasn't based on some diagnosis of CRPS. It was based on the actual presentation of facilitation or disinhibition.
Probably something not that people are going to see very commonly.
Yeah, I think it's relative to where they are, right? Like if you're hanging out and if you're working in a CrossFit gym, I don't think you'll see too many of them, I've seen some in sports performance, but not glaring like that, in sports performance usually pick up, the disinhibition relative to a joint, but not because of their pain, because they want to get more performance out of that body part, but relative to pain, yeah.
Okay. And now about the pain neuroscience education and cognitive behavior therapy. So which ones do you think that respond better to those approaches?
Pain, say that one more time. I'm so sorry.
The pain neuroscience education and the
What is
cognitive.
that? Oh, pain neuroscience education. Give me an example of what that
I think
really
about
is.
Adrian Lowe, or like his cards talking about pain and
Doesn't he have a card that talks about safe pain?
Yes, I think he does. Yes.
Yeah. So of the three mechanisms we talked about, central sensitivity, affective, motor autonomic, the card that talks about safe pain, which one would you think is more appropriate to use?
The fear avoidance, central sensitivity.
Yeah.
Yeah.
So to me, it's aligning these, right? Relative to these factors. Somebody who's is struggling emotionally, I'm not going to sit here and have a conversation about safe pain.
Yeah.
Now, if Adrian's got a card about emotional coping, that one might be better aligned for that, right? You know, I probably wouldn't use that card when I'm talking about somebody whose brain's not recognizing their body. But so pain neuroscience education to me has gotten itself too broad, too many factors. We're making the assumption everyone has all of these factors, as opposed to really assessing what's the dominating factor.
Yes. And it's just a lot of different things that can get confused.
Yeah, but well, to me, everyone in this space and what they're selling in regards to their pain neuroscience education, they all have like these three elements. So if you're using, whether it's Peter O'Sullivan's, whether it's the, NOI DIMS and SIMS, whether it's Adrian, like challenge yourself to say, okay, which one is for, the one that needs to understand safe versus which one that's more stress and emotions and social? And is any of them dealing with when the brain doesn't recognize the body? Yeah. And I feel then what you've embarked on or committed to may be more utilized within the clinic for people. But to say I'm going to just, hey, visit one's going to get this card, visit two's card. And so I'm running everyone through my cards. We might not get learning. Learning changes pain. Education doesn't. And they learned that with Explain Pain. When that came out in 2000, they thought that was going to be the bomb, man. 20 some years later, it wasn't about the education. It was about the people who learned. And how do we get people to learn? It isn't about the education. It's about the application of the knowledge is learning. And so these are where we're going, move forward with this type of pain neuroscience education. It's like, I'd rather see it say, how are we dealing with learning? Because that seems to be tied to a change. Yeah. And then are we screening and aligning the education that produces the learning, with the person that has these factors that are dominating their persistence? Yeah. And I don't think the patients technically need to know the mechanisms. I think the clinicians need to understand them. They need to organize how their questions are going so that they can get some information. They need to be able to screen it in a physical exam to say that today this is the dominating issue. No different than when they do it with derangement versus dysfunction. I mean, we can do it with derangement versus dysfunction. Why can't we do it with central sensitivity versus affective? We should, so the concept is the same. It's just that, that understanding. Clinicians need to be armed with this.
Yeah. And do you have like a way that you go about that on your assessment that you could like help clinicians kind of structure that on their thought
Yeah,
process? Do you have any?
Yeah, very good. I tell people, my assessments are probably if you're, using the McKenzie eval form, if that's what you're familiar with, I'm not saying, location of symptoms is obviously important. Frequency of symptoms is obviously important. Better and worse is obviously important. The effects of medication and treatment are important. The onset is important. Nobody's going to say these are not important characteristics. But I'll always throw in 2 questions that help me. Okay. At the time of the onset of the symptoms, what else was going on? How was the family? How was the wife? How was the kids? How was the dog? How was the job? So I'm allowing myself on visit 1 to appreciate where that person was at the time of the onset of the symptoms. Even if it was a trauma, I hear this often with athletes, it was a very stressful time. Now, I'm not that day saying, whoa, it's this. But it allows me to go back when things don't map up within 2 or 3 visits of saying this is a dysfunction and they're remodeling for 14 days and there's no change. And I'm like, this ain't no dysfunction. This is an emotional dysfunction, not a emotional dysfunction, right? But it allows me to make that call because I was able to pick that up at the time of the onset of the symptoms. Other things were going on in the life. And I always ask, when I'm asking better and worse, the effects of medication, the effect of ice, the effect of heat, what's the effect of stress? Does stress have an impact on your symptoms? It's a simple yes and no. I am always amazed at how many people say yes. And so when I hear that, again, doesn't mean that I commit to them that day. They're an emotional wreck and we have to work on their emotions. Thanks for laughing. But I do know then if I'm working a peripheral mechanism and my yellow flag is high in the emotional social confidence area, and at 2 weeks, they're not mapping out like I would think, then
you have a way to go.
I have a way to go and I have evidence to go back to a conversation that they gave me. And I don't then seem like that day when I say, well, how's stress? Like you're coming out of the blue with that question, which completely breaks the trust.
Mm-hmm. And then they're going to say, it's my shoulder. That's nothing to do with my stress.
Well, but we and it makes sense. I mean, if somebody did that to me, I'd be like, oh no, you ain't taking me there. Right. So, I feel like if you can get those 2 questions built into your interview and just ask them, don't diverge onto them, it sets you up in a couple weeks to have to say, you know what, you brought that up to me. How are you coping with this?
So what's the second question? Did I miss it? So what else happened on the onset? And what was the second question?
Does stress influence your symptoms?
Okay. Yeah.
When you're going through your better worsening and you're at, medications, we ask all these kind of things, which are all good,
Then you go on vacation and then everything is good. Nothing hurts.
Yeah, central sensitivity, come on, you know it. They're the ones that love red wine. They know alcohol affects their symptoms for the better. They'll admit to, the opioids and, gabapentins and all that help because of the central-based opioid mechanisms. But people who are dominated by the affective mechanism, they rarely admit that narcotics help. They will admit that tramadol does, medical marijuana does, antidepressant does, and anti-anxiety does. So even if you understand the medications that are having an effect can help you understand a dominating factor to the 2 subgroups. Yeah. Mm-hmm. We just don't think this way,
Yeah. It's really good to organize your thinking because that's all things that we see in our day to day. We know that when you talk about, I can think about all the patients and, It's just being able to identify and then address correctly.
And reassess.
Yeah.
And reassess, because, you know, it is a dynamic spectrum that people are going through. And, you know, that is why, you know, we constantly assess until there's nothing left to assess.
Yes. Building those different skills that sometimes you don't think as much about them. So
true.
Annie, we talked a lot. Anything that I forgot to ask you that you want to mention about all the subgrouping and the approaches and connecting them?
Well, you know, if you don't mind, I'm going to tell you, if this talk is interesting you, you know, the only book that I know actually talks this way is the book that Melissa Kolsky and I wrote, A World of Hurt, A Guide to Classifying Pain. And we basically talked about chapters 6, 7, and 8 today. And if these characteristical patterns are things that you feel are helpful, we have all the charts and all the information that you would want to organize your thinking and your practicality relative to that book. So that's what I'll say, because people are always saying, hey, what article can I read? I'm like, well, that book was written off many articles. So, but it was really based off of 20 years of putting it into practice and watching the patterns and getting down to the have-tos, right? And so if this does interest you, I would say that's probably the best reference at this present moment that discusses all of those subgroups, right? Yeah.
I definitely have to go back and read those chapters.
Well, you'll read them differently, right?
Yes, with this great overview that you gave us, that's very helpful.
Yeah. And then, you know, we have the World of Hurt courses that are going on. We got one in 2 weeks where we're going to actually cover this material and the central nervous system. And so, I mean, these are things that are going on. And if you want more information, you can definitely contact me at World of Hurt 2, World of Hurt number 2 at gmail.com. And I would love to brainstorm on how we just serve people that are suffering in these areas more with you, and provide references and materials for them. So
awesome. That is very helpful, Annie. Thank you so much for coming and brainstorming here with us and giving all this great overview and summary. Just make me feel like I need to read and study a lot more about this topic, because I think it's super, super relevant to everyone's practice. So it's something that everybody should know more about. So I appreciate you willing to, take some time to help us understand this a little better.
Well, it's been my pleasure, and you're welcome. I look forward to what our next topic could be, right?
Come up with something.
All right. When you're dry, let me know, will you? We can always come up with how I apply this in the canine practice. Stay tuned. Yeah.
Oh, thank you so much, Annie.
All right. You have a good day.